Well, good afternoon, everybody. We'll get started. And first, let me say it's an honor to be here on the dais with this esteemed panel. And although you have their bios, I just want to give you a little bit of insight into the gentleman that I'm with, as I've met personally two of them before and had a conversation with Peter earlier this week. And just some insight that, again, that's not in their bios. For example, with Dr. Redlener, who, although now is predominantly in an academic situation, has the ability to understand the scope of the population in general, having provided care to both urban, rural, and international underserved. So it's someone who has boots on the ground experience, even though we're seeing him coming from Columbia today. I think that he's also probably known as Dr. Mega Disaster right now, based on, but for a good reason, because he's posed the appropriate question that will, the question of whether or not all our efforts in preparedness prepare us truly for the mega disaster, and I'm sure he'll speak about that. Dr. Cole, who has again posed a question of should we look overseas at methods to address the threat, because on a daily basis, as Dr. Flynn mentioned, states like Israel handle on a daily basis what we handle mostly, unfortunately, during exercise. And I'll put in a pitch in for a symposium that Dr. Cole is sponsoring on July 15th at UMDNJ on terror medicine and security. And Peter Margella, who has looked at a systems approach and has brought his experience from working with the military into the civilian world and does a great job of combining the both of those. And I'm sure his discussion is tailored around that. I think if you look up here, you'll see this is the first panel that doesn't have a public rep on it. So Dr. Flynn, like the Boston Fire guy, could you send help, please? You know, we'll be hearing the non-public address of systems here with no ability to defend it, but I think that's good, because I think you're not hearing any tailored comments at that point. My job here is to frame the discussion. I'll do so with some of the following points to ponder, either during the discussion or after, when we involve you as the audience in general. And the first question is, why are we preparing? Is it worth the cost and the effort, the billions and billions of dollars, the staff effort? Does the benefit outweigh the cost? Just a generalized question. The second is, if we prepare, what's the focus of our preparation? Is it the lone terrorist, the asymmetric group, the state-sponsored terrorist, or the threat of a mega disaster or mega illness? Or is it everything? And finally, if we accept the fact that we need to prepare, what does that mean? How do we know that we've succeeded? Will our plans work? Because as in general, these plans, and especially with the health community, are not necessarily empirically based. We have never had a pandemic influenza in our time. And the question is, are we doing the right things? So with that, I'm going to turn it over to the panelists. And first, I'll ask Dr. Erwin Redlener to step up and address us. Thank you.
So I guess keyboard's in here somewhere. There we go. Just pull it up.
Okay. We're going to do a slideshow. And then from the beginning.
Okie dokie. So, thanks, David, and good afternoon to all of you. This is something that I have been speaking about, that is to say, mega disaster readiness, for some time. And if I had a long time to speak with you, I would give you some of the good news. Unfortunately, I only have 15 minutes. And in that 15 minutes, I would like to make the case that while we've made a lot of progress as a country in being able to respond to things less than a mega disaster, which I'm going to define in a minute, we're pretty much stuck in a very difficult situation where the progress, so to speak, has been very limited when it comes to preparing for mega disasters. And I want to tell you about 4 particular barriers to getting prepared that I think are relevant to this question of public health readiness. But before I do that, I just want to address 3 caveats. The first is to emphasize the point that I just made. My concern, and I think our society's concern, should not be so much on our ability to respond to big emergencies or small disasters, because these are generally, in fact, well managed now by local and regional resources. So the issue is about the prevention of and response to mega disasters. And just so that we're on the same page, I'm calling a mega disaster a catastrophic, very high consequence event, no matter what the cause is, whether it's man-made or natural, but a phenomenon that overwhelms or threatens to overwhelm local and regional response capacity, but in very specific ways. So first thing is that does the disaster present a situation that makes local and regional capacity to rescue endangered survivors possible or not? So if that gets overwhelmed, we know we're dealing with a situation that is going to require something much more than could be provided in a local or regional planning effort. The second thing is there a significant backlog of victims who have been rescued or who are self-rescued, who need medical care or other kinds of appropriate support but simply can't get it. And a third criteria would be the inability for us to protect vital infrastructure or prevent significant property destruction. And a fourth element of a mega disaster could be uncontrolled societal breakdown. You don't need all four elements, but you need some combination of these to put us into a realm where we need to worry about our ability to deal with the situation. The second caveat, which is the most vexing for me of all of them, is that we shouldn't really describe preparedness until we've defined what we mean by prepared. And believe it or not, ladies and gentlemen, I don't think there's a definition of prepared out there. And part of the reason is that we're talking about a potential multiplicity of disasters and situations that we need to be prepared for, and lots of variance on this theme. But without defining prepared, even if it's somewhat arbitrary, we can't establish goals or benchmarks to see how we're doing. So if I don't know where I'm going, how am I going to describe what I'm doing in terms of a benchmark? It's just not possible. And furthermore, we can't really assess progress by measuring process. So when an agency representative, a government agency on any level, comes and says, well, we're prepared, here's the list of things we have done to get prepared, and we don't know the denominator of what we're aiming towards, there's no way to evaluate that report from the agency, whether it's Homeland Security or your local Office of Emergency Management or your local health department. So until we have the benchmark clear and the denominator and the goal clear, we actually don't know what we're talking about. So in effect, we don't actually know what we mean by a prepared city or a hospital or a health system or a prepared country for that matter. So we're starting off with some fundamental problems here that unfortunately we have to put on the table. The third caveat is that effective preparedness for a response to or recovering from mega disasters is extraordinarily expensive. And it clearly, and I wholeheartedly agree with Steve Flynn, that there's elements to this, including, and maybe centrally, citizen readiness. But the fact of the matter is, if we're going to really prepare for nuclear terrorism or pandemic influenza of a severe nature, who is deciding whether that priority is more important than getting children immunized? We have now 1 million homeless children in the United States. We've lost about 1 million children have actually lost health insurance since the recession began 17 months ago. We have big, immediate problems. Do we divert resources in a limited resource environment from dealing with basic public health or other kinds of needs in society to spend and invest in the big picture of how do we really prepare New York or Washington for a nuclear catastrophe? I'm not suggesting that I have an answer to that. I'm just telling you this is a question that has not been debated, and there's no forum for this debate that has meaning to the people that actually make policy and will make those decisions. This is something we need to really worry about. In the meantime, let me state definitively that we're simply not ready for mega disasters, and I want to just present really 4 quick critical barriers here. The first is that preparedness policy, whether we're talking about public health or any other part of the preparedness system, we don't find that evidence or even expert consensus is uniformly driving our decisions, which is a real problem. If I was practicing medicine in an environment with, I'm a pediatrician by background, in an environment or where there's no evidence available and no consensus about what to do, and I'm just making random decisions, we get quality of care that you exactly would predict. It's lousy, it's random, it's disjointed, and it's dysfunctional. But that is precisely the situation with billions of dollars being spent and very little in the way of evidence driving policy decisions about that. We did a review of 303 articles in the public health disaster literature between 2002 and 2007. This was basically all that we could find. And of those 303, less than 19% had any sort of scientific merit that really should have passed a peer review situation. The rest were commentaries, quote-unquote lessons learned, anecdotes, and completely inadequate. Yet based on this, we're making decisions about what we want to do in our public health system, and this is not a good thing. And this makes, in fact, not only do we not have the benchmarks I said before, we don't even have the science to establish the appropriate benchmarks if we try to assess where we are around major disaster preparedness. The second barrier is that the scale and scope of planning for large-scale disasters is grossly inadequate. And if you remember nothing else other than this point, I just want to tell you something. We talk about pandemic influenza. There are gigantic volumes that Health and Human Services have produced on what should be done. If we did what they're recommending, we would be spending 50 times what we're currently spending. So we have a disconnect between what is needed and what we're actually doing or spending. And to emphasize this point, let me just say this, that planning for a local emergency or medium-sized disaster, let's say a nuclear or radiation-contaminated conventional bomb or a dirty bomb exploding in a city is relatively easy to deal with. New York City is prepared to deal with it. Now, when do people come back and how do you decontaminate? These are not, I don't want to minimize those problems, but they are dwarfed by the reality of a nuclear detonation of a 10 to 13 or 15 kiloton nuclear weapon in lower Manhattan. We can do the former, we simply cannot do the latter. We've only begun to very superficially look at this, and for a lot of different reasons that I don't have time to go into now, maybe we can discuss that later, but we're not doing the hard stuff. We're simply not doing it. We don't have the capacity, we don't have the will, we probably don't have the information to allow us to do that effectively. We're not planning sufficiently for special populations. Again, this is hard. You want to prepare New York City for a mega disaster? You better be ready to speak 50 languages to the various ethnic and cultural communities in New York City. You better understand the cultural and ethnic drivers that will change or affect people's behaviors in that situation. If we've just done a one-size-fits-all plan, and here's a little booklet from the Office of Emergency Management, which is not the case, we've got more than that in New York, you're going to be in big trouble. But the reality is we failed to plan in general for dealing with so-called special populations, whether they're culturally different or they're little children or they're people in hospitals or whether they're elderly in nursing homes. We're really just scratching the surface. The disconnect between, in the public health community, between needs and resources is extraordinary. So we believe it would take about somewhere between $5 and $6 billion in one fell swoop to bring the 5,000 U.S. hospitals up to speed in terms of some level of basic disaster preparedness. And then after that, $1 billion to $1.5 billion a year to sustain that level of readiness. And the fact is, we've never given the big bolus initially, and we're providing about $400 million a year to try to do a job that's really incompatible with success. So we're giving big hospitals $60,000 a year through federal resources to quote-unquote get prepared. So you're running $1 billion healthcare system, and here's $60,000 to get your hospitals ready. It's just obviously, as a matter of scale and reality, not possible. Just a couple of things I want to say about pandemic flu, because sort of the ultimate public health challenge. So dealing with a population of a little more than 8 million people in New York, the H5N1 virus in a serious attack would have about a 30% hit rate. So in other words, 30% of the 8.2 million will get sick. There may be very, very minor symptoms, or they may be really sick, but about 10% of those infected would need to be hospitalized, and about 2.5% of those infected would not survive. And let's say we're talking about a 6-month flu season. So the reality is that we'd have 2.5 million sick people, including 600,000 children with avian flu, 60,000 deaths over that period of time from the avian flu, with 15,000 children being fatalities. 200,000 hospital admissions, 300 deaths a day, and, ladies and gentlemen, we simply don't have enough. We're just talking about scale here. Vaccine, antiviral medications, hospital beds, ventilators, and so forth. And we don't have enough by such a wide margin that it's almost unthinkable how disconnected the need is from the resources being provided. Governor Pataki, a few years ago in New York, announced with great fanfare in a press conference that he was going to invest $29 million in New York State pandemic flu planning. Well, what did we need? We needed $480 million, really. So, you know, against the denominator again, that was really just almost nothing. But received a lot of fanfare because it was something that was being done, even though it was completely disconnected from reality. And then schools closed, parents ill, and so forth and so on. Little assistance from the outside. So, big problem, very, very little plan, and even fewer resources. Third barrier, lack of adequate horizontal and regional coordination. I can't begin to tell you, yes, we are doing some regional coordination. It is superficial at best in almost every place in the country. The lack of coordination is horizontal, vertical, diagonal. There's not enough coordination to even really talk about. Yes, they're looking at catastrophic regional catastrophic response systems and all that. That's fine. Their timeline is now out to 2012, 2013 to finally get things in order. That'll be, I guess, a decade after 9/11. We don't have the relationships between federal, state, and local resources, among resources of various agencies. People are routinely leaving the Red Cross out of planning, or citizen readiness and so forth, and this is unfortunately just a big mess. The situation among government agencies, in spite of what we frequently hear in reports from government agencies, is that we still have, in fact, a tremendous amount of dysfunctional discoordination among the agencies that would be critically involved here. And we talked before about funding, and I'll tell you that there is some funding for regional planning. Again, it is so far mismatched from the actual need that it's really hard to understand how we're going to come to grips with this reality. The fact is that when we're talking about things like, when we're talking about things like a nuclear detonation in New York City, yes, the target might be Lower Manhattan with a 12-kiloton device, but the consequences are really, in fact, they're regional. They're entirely regional. The healthcare system of most of New York would be wiped out. What will happen is people will evacuate by the hundreds of thousands and millions to the surrounding communities in at least 4 states. And that means that the readiness for mega disasters of this nature and the preparedness that has to happen really needs to happen in the communities that are outside the main target area. Now, just so you understand this, the modeling for a 10 or 12 kiloton nuclear weapon explosion in Lower Manhattan shows that somewhere between 75,000 and 100,000, 150,000 people would be killed instantly by the effects of the nuclear blast. But 10 miles from ground zero, people will survive. In between ground zero, where you're basically going to disappear, and where you're probably going to survive without much immediate problem, is what we're calling, from a public health point of view, the survivable gray zone. And the fact there is that if you have information, now as citizens, and again this is something that Steve Flynn talks about, the survival of several 100,000 people in the modeling will depend on what citizens know, and it's really pretty straightforward. It's a stay or go question and a timing of those two behaviors. But in the absence of having people engaged in their own sense of participation, becoming resilient, and knowing that they have some power to survive in the event of a large-scale catastrophe is absolutely critical, and something we really haven't begun to address. And the final barrier is really a cluster of issues that I'm putting under this notation of systemic political paralysis. So 85, 90 different congressional committees and subcommittees have jurisdiction over some part of Homeland Security or preparedness. Is that the number, Steve? Somewhere there. Okay, yeah. So that lends itself to a hyper-siloizing, hyper-silozation? 5 minutes, okay. Peter's going to talk about this shortly. You have such disorganized funding streams and directives coming from the federal government that it's almost impossible to get any sort of control about what we're really accomplishing or where we're really going. And if you add that to what I said at first, that we don't even have a definition of what we mean by a prepared city or a prepared public health system, you see the makings of absolute chaos and confusion in the process of trying to get the country ready. The second thing is that I guess I've been involved in public health since 1971, seen a lot of government programs come and go, and I must tell you, I don't remember ever experiencing or knowing about government programs with as much money invested and as little accountability for what's happening with that money. I dare say there isn't a single person or agency in the federal government, whether it's GAO or any specific agency, that can tell you how much money we've spent on preparedness and Homeland Security and what we have gotten for our money. The metrics don't exist, the will doesn't exist, and the overlying structure, this jurisdictional chaos that I'm just mentioning, is itself a barrier to getting accountability. And why we tolerate our taxes being spent like that, especially during economic crises like we're experiencing, is really beyond me. And the other thing is this, what I'd like to say is the failure of federalism, which actually doesn't work when we're trying to get prepared. I know for a fact that the White House, at least the immediately former White House, was in fact concerned about the possibility of nuclear terrorism. Twice I briefed one of their nuclear readiness teams there. So imagine this. So we're in D.C. and in the White House, big concern about the possibility of nuclear terrorism. You can use this as an example. But go to any community in the United States, whether it's New York or Washington itself or Chicago, and the level of response to that national concern is either diluted or ignored or unaware. And this is a really big problem, and it's a disconnect that's in part due to the fact that money is channeled is appropriated by Congress, it goes to the federal agencies, it goes to the state governments, and it goes from there to local jurisdictions. And along the way, lots of people get to decide, and lots of organizations get to decide what it is they're going to do with that money. So if New York City says, we're ready now, but we weren't ready for the last 7 years to think about nuclear terrorism, that's their call. And that's very, very bad for creating an effective web of safety and readiness for the kinds of things we're talking about. So I'll stop by saying that we have some very, very difficult decisions to make in an environment that last year I was saying is a resource-limited environment. I don't even know how to characterize it at this point, except to say that we don't have $1.50 to spend, and I'm telling you that what we're facing are enormous challenges with enormous price tags associated with them, and we need to get the mechanism. And by the way, I don't care if we had intelligent discourse, society, and decided that, yeah, we may be worried about nuclear terrorism, we simply can't plan for it, because we've got to immunize children, we've got to get people into a healthcare system, we've got to build better roads, whatever it is. We don't have the forum to make those decisions. And in the absence of that, we are left holding a very big bag. We're just in a dangerous situation that hopefully we'll begin to address under this new administration. I think are you depressed? Sorry, okay. Thank you. Yeah.
Thanks, Dr. Redlener. Next, Dr. Cole, don't sit down. You're up next, so if you would come right up.
I'll start. I'm very lucky in a way, you are too, to have heard several great presentations, but for me especially, having heard Steve and then Erwin, they actually are wonderful stepping stones to exactly where I want to go. I'm going to talk about terror medicine, a term that's probably not familiar to many of you, but I hope for the good of all of us, including the entire nation, that you will become more familiar with it. We will all become more familiar with it. I relate that to emergency preparedness here. And here I'm going to be dealing with 4 elements that comprise terror medicine. 2 of them, one of them is the cloudy, fuzzy notion that Erwin just mentioned about preparedness. And that's number 1. And then the second is going to deal with incident management. The third having to do with nature of injuries as consequent to terror events. And then the fourth is psychological consequences, which relates to resiliency. So 2 out of 4, you've just heard the intros from the gentleman before us. Terror medicine is a term that actually emerged in the early part of this century, 2001, 2, 3, largely as a consequence of what was happening in Israel when they were going through what was called the Intifada, the Palestinian uprising. There were multiple terrorism events over a 5-year period. There were over 450 successful ones. There were some 20,000, according to the government of Israel, that had been launched and obviously mostly thwarted. But terror medicine is not brand new. The term emergency medicine, which is probably familiar, I'm sure familiar to all of us, came into vogue perhaps 40, 45 years ago and evolved into a separate distinctive discipline. Management and treatment of unexpected illness and injury is how it is in a shorthand defined. And disaster medicine, more recently, perhaps 15 or 18 years ago, began to take on an expression that was understood, eventually evolving into a separate field. And now terror medicine, the management and treatment of health problems associated with terrorist attacks. Now, I'm not only going to be talking about terrorism, even though that's the focus of the discussion, but a lot of the lessons, as you will see, would relate to non-terrorist, non-human intervention kind of attacks or events. So I'm not going to define always which is distinctive, but here and there when you see something that I will point out to you is really a distinctive consequence of terrorist attack. So preparedness, the first item, the first element. Erwin, you are so correct that there is no single formula that defines and describes what preparedness is. It's easier to say, and you're going to see some evidence of this in a few slides down, what adequate preparedness is not. But in this case, as a good start, I think, as we look at what's called the Strategic National Stockpile, what you're looking at is, and Erwin and I have been together before an audience when I mentioned this Strategic National Stockpile. There are 12 of these huge stockpiles, and in them is virtually a mini hospital with surgical equipment, medications, and virtually anything that would be needed to be ferried to a particular location if there was an urgent situation. There are 12 of these around the United States, and we believe that within 6 to 12 hours maximum, any location in the United States could receive at least one and perhaps more of these stockpiled capabilities. Now, I said it would take a 747 to carry, a Boeing 747 to carry one of these, but perhaps it would require a little more space than a single Boeing 7. And what's in this? Well, as it relates to terrorism in particular, there's anthrax vaccine, there are antidotes to various chemicals, including sarin, nerve agent, there is smallpox vaccine. You would not ordinarily have that in a hospital stockpile itself. Preparedness would involve having capabilities at medical facilities, hospitals in particular, for decontamination. And this is a picture in terms of preparedness at Robert Wood Johnson University Hospital in the year 2005, in April, during a top-off 3, which is a top officials 3 rehearsal drill for a bio-attack. Sitting here in our group today is Dr. Cliff Lacey, who was then the president and CEO of this hospital. And when I said, look, he saw this slide. Not only did he see it, I was standing next to him when I took this picture. And he said, well, you're not showing enough. You're only showing perhaps the 200 or so that I thought beds that had been set up. And he said there were 300 and a capability of an additional 100. So that could have been 400 or so surge capacity beds that could have been brought out fairly quickly. And by way of a demonstration during that week of the mock bio attack, they were not only brought out, but mock patients were placed in there. And this is pretty good, considering that the base bed capacity of the hospital is 600, so it's something like 80% over what the required an ordinary amount would be. And here's a drill at Hadassah Hospital in Jerusalem, and I'm going to spend a fair amount of the remaining part of my discussion with reference to what Israel has done, because as Steve Flynn has wisely noted, and others who will pay attention to these things note, Israel has had some very difficult experiences from which they have learned to deal with issues, protocols, terror attacks, and I don't remember who it was. It might have been you, Steve, who said you're not as worried about suicide bombers as a mega attack, or maybe even Irwin, whoever it was. I would worry a good deal if there were 5 or 6 suicide bombers who detonated themselves in different locations pretty much at the same time. One in Dayton, Ohio, in a shopping mall, or a theater in Dallas. And you do this and you really can, if not paralyze the country, you get a lot of people who would no longer be going to shopping malls for quite a while, or theaters, as would be an aftermath, which is in many cases highly psychologically driven, but still hugely disruptive. So in Israel, they do have these attacks through rehearsals and then the real ones. And I would call the signal aspects of preparedness having the appropriate amount of supplies, types and quantity, equipment, structural enhancements. And here I can say that because of financial constraints in part, we do not invest that much in structural enhancement relative to preparing for a disaster of any sort, and especially terrorism. But I was struck as I visited Hadassah Hospital. Some of you in this room were with us at the time a few years ago. They had just completed an emergency department which created a 50-bed capacity which could easily be doubled, literally within minutes if necessary. Structural enhancements included 4-foot thick walls in case there was a 15 kiloton atomic attack, but certainly a substantial amount of capability to withstand a terror event or other kind of disaster event. Ventilation systems that included a self-sufficient recirculating capability for ventilation, so that in a 7 or 10 day period there would be no environmental air brought into the system in case there was a poisoned atmosphere, either by way of biological agents or radiological or chemical. And then, of course, education, rehearsals, exercises. 13 minutes left or 13 minutes done? Okay. Incident management. This slide and the following two are going to be depictions of what preparedness is not and should not be. These three women are nurses who were at a nearby hospital relative to the location of the Murtaugh building in Oklahoma City. They came rushing. Not one of these three, but another nurse, among others who had rushed to the scene, was killed because she was not equipped to understand how you try to help a patient when you're amidst rubble, when some rubble crushed her and she died. This picture was provided to me by Dr. Eric Freiberg, who's a trauma surgeon, chief of trauma surgery at the University of Florida, and he makes a very big point of saying, what's wrong with this picture? Not only these three women rushing with all the best intentions in the world, but not the capability to do very much. Crossing police lines, nobody stopping them. This is a picture of the Madrid bombings, obviously a significant time. When I say significant time, many, many, many minutes after the detonation, when people are being helped, those who are just lying around, being helped by other passengers. One of the reasons we can clearly see that this was a fair amount of time following the detonation is there's no evidence of fire or smoke, and you also see no evidence of emergency responders on the spot. Similarly, a year later in London, a lot of the help given to passengers of the train who were injured was done by some folks who, with good intention, goodwill, and absolutely no training, happened to be nearby and tried to help. This much I know from looking at after-action reports from the London incidents. You know that there were 3 underground and then 1 bus bombings, and 56 people died. About 700 or so required hospitalization. This was fewer casualties than in the previous events that I talked about, Oklahoma City and in Madrid. But you should know this. The first patient
who needed hospitalization did not get to a hospital until 57 minutes as measured from the initial detonation. And 4 hours after that detonation, there were still people who needed hospitalization who had not been brought there. And it wasn't because there weren't sufficient medical capabilities in downtown London or hospitals. There was not sufficient planning, preparedness, and rehearsal. In Israel, certainly they had a lot to learn beginning in the late part of the 1990s and into the 2000-2001 period when this intifada emerged. Now, Israeli protocol, Israeli rehearsal, and on-the-ground Israeli experience allows initial patient carryover to hospitals literally within minutes. Now, of course, if there's going to be a terrorist bombing in some rural place where there's no hospital nearby and there's not a quick response by way of ambulance capability, the story would be different. But in all of their metropolitan areas, literally within minutes, people have begun to be just brought up and brought to a hospital. This is contrary to a lot of what the usual protocol is in the United States and elsewhere. The inclination is try to give as much help as you can, as badly as a patient might need it, even on the scene, rather than scoop and run and bring the patient to the hospital. In Israel now, within the first hour, 90% of patients who need hospitalization are in a hospital. I can go into the details of protocols, but there are things to be learned from that. And then in the hospital, there are teams ready to take care of people. What you see is the fourth floor of the hospital of the Western Galilee, which is 6 miles below the Lebanese border. A missile hit the ophthalmology department on July 28th. This is what the department looked from inside, utterly destroyed. This is what the rest of the hospital looked like. That's a 400-plus bed hospital. And what you see here is a typical room throughout that period of the Lebanon war, when there was fighting, when Hezbollah was sending rockets in and Israelis were firing back and moving troops back, because the entire hospital had been moved to a pre-prepared, underground capable facility where beds were rolled out, and there were some 400 patients who were brought downstairs during the first hour of that war. Now, not every hospital would need it here, or even in Israel, but those especially, well, these are lessons for what can be done. Signal aspects of incident management, triage initially at the scene of an incident where you make quick decisions about where you send patients so you do not overload any particular hospital, and then at the time of hospital entry, ambulance inspection at the hospital perimeter. That's for terrorism purposes. You do not want either somebody with munitions or bad ideas about to be brought in under the guise of being a sick patient. Cell phone lines are sometimes purposely blocked if you anticipate the possibility of a detonation of a weapon that's inside a hospital or a facility through a cell phone from outside, and communications capabilities are necessary and ongoing in most Israeli areas now. Injuries and responses. I'm going to run through some of this. The missiles that were sent in from the north, from the Hezbollah area into Israel, there were 4,000 of them during the month-long period between mid-July and mid-August of 2006. They were carrying ball bearings and little metal pieces, and this is what the side of a car looked like from the spray of the ball bearings after. Similarly, when suicide bombers do their work, they often are packed with nails, bolts, and pieces that have a similar effect, but this time to a human being who happens to be, unfortunately, in the area of the spray. An x-ray of somebody who has his body riddled with nails. This is maxillofacial surgeons who removed, you can see this object, this circular-looking object in the lower right. Does anybody know what that is? Yes. This is correct. It was a piece of a watch from the terrorist's arm, a suicide bomber. This was extracted and had been embedded in the patient. This is just to move us out of gear. Does anybody know what this is? Well, yes, anthrax is correct. During the anthrax outbreak, and you know we're walking distance from the location of the mailbox that was used to mail the letters, at least that's the presumed mailbox, that There were 22 victims during that anthrax outbreak, at least 22. 5 of them died. 11 of them were inhalation victims, 11 of them skin or cutaneous victims. But during the first several weeks, when some of these patients with cutaneous skin lesions were going to the doctor, virtually all of them had been misdiagnosed. So the signal aspects of injuries, the nature of injuries: numerous penetration wounds, blast injury, blunt, inhalation, crush, burns. Now, what I just spoke of, that list, clearly is something that at one time or another, 1 or 2 of these would be seen in a single patient in the United States or elsewhere. But I've talked to many trauma surgeons, and I said, how many times have you seen a patient with almost or all of these? None. But in Israel, as many as 2 dozen, 3 dozen victims from a single suicide bombing can suffer from this combination of injuries. What do you decide to do first? What do you treat first? The penetration injuries, possibly there's been a vessel or a spleen disrupted or broken. Do you go for the bowel that's been disrupted or ruptured? There are protocols now in place based on hard experience that we can learn from here. Finally, psychological consequences. Every psychologist and psychiatrist that I've spoken to who's been either treating patients or familiar with how patients are treated understand that during a terror attack, the consequences, the psychological consequences, and the challenge to resiliency is so much greater than if it's an automobile accident or another kind of fall. How do you deal with it? Well, you create a patient base of knowledge or a whole population base of knowledge that you will be taken care of. I don't mean a socialized or nationalized system. That the country, the people, the community are there for you for years after people will go through physical, psychological care. And this is the closing part with these 3 or 4 slides. This is one person, but I can tell you, having interviewed probably more than 100 victims by now, survivors, that this is fairly typical. This young, attractive woman, age 23 in the year 2002, was a victim of a suicide bombing. She was comatose for 3 months. 80% of her body was burned, shattered bones, lost the hearing in one ear, lost the sight in one eye, lost the use of one lung. She had extensive physical and psychological therapy. 6-8 months after the incident, her mother was standing next to her. Her whole body virtually was scarred. She had to wear this burn suit, a dreadful, difficult thing, for 2 years, so that although the scarring would take place, the chelations, the bumps would not appear, and because of the suit compressing things. And when I met her in 2004, she said, there was a period when I was very angry, but as my shrink said, that was normal, it passed. Bitterness leads you nowhere, you want to live. She got married 2 or 3 years ago, and I just got an email, literally last week, that she had had a baby a week before. The final, or next to the final slide, the signal psychological issues are unusually intense early reaction by people who experience a terror event. Immediate psychological intervention is essential, but contrary to what you might do after a group victim event, like an automobile situation, you don't bring terror victims together to work out their psychological issues. Why? Because, as I learned from some psychiatrists and psychologists in Israel, many people don't see what's happened. The smoke has covered the whole area. They don't have any notion exactly of the visuals of what happened, but somebody else might have seen a suicide bomber's head fly right in front of her face and right after the event. You do not want that person retelling her experience and stories before the others. Then, of course, responders and therapists may end up needing this care. Well, this is all part of a compendium of a book that was published a month and a half ago called Essentials of Terror Medicine. There are 35 contributors to this book, many of them who've had hands-on experience with terror medicine. But as I said before, there are many lessons to be learned that extend beyond just terror incidents that would apply to non-terrorism or even non-man-made experience. Thank you. Close it out. Right. Okay. Is that what you want? No, that's, well, we'll just minimize.
Yeah, just minimize.
Okay.
No, I'm ready. I'm going to speak.
Peter, I'm going to turn it right over.
Thanks very much. Well, in honor of this opportunity to speak at this esteemed academic institution, I'm going to do something completely unusual these days, and I'm going to eschew using PowerPoint in favor of a chalkboard. It's become so ubiquitous in the Pentagon during my last couple of years in the military that instead of giving people medals and letters of appreciation at the end of the tour, they now give them the PowerPoint ribbon with gold mouse device as their award. Well, as my bio points out, I was a career naval officer in a community called the Plans, Operations, and Medical Intelligence Community, or POMI. My last 2 jobs were as the senior planner for the Joint Chiefs of Staff, Chief of Plans and Medical Plans and Operations, and then the Director of Medical Contingency Operations in the Office of the Secretary of Defense. For about the last 4 years, I was on active duty. Excuse me, sir. Last 4 years, I was on active duty. Not surprisingly, I spent a lot of time on loan to the likes of the White House, the Homeland Security Council, the brand new DHS and HHS, helping to write or being the principal author of a number of national strategic impact plans addressing issues in this new era of asymmetrical threats. And that was partly due, well, in no small part due, rather, to the fact that amongst the federal partner agencies, only the Department of Defense actually minted, bred, trained, and provided career opportunities to officers in the medical planning arena. So not surprisingly, we became something of an important commodity to the rest of the federal partner agencies when they were trying to put their arms around some of the threats that are now omnipresent in our environment. So with that as background, when I retired in July of 2005, I was asked a couple of months later to come see Dr. Jeff Runge, who at the time was the Assistant Secretary of Health Affairs for the Department of Homeland Security. Actually, he wasn't the ASHA yet. That title was granted to him in 2007. At the time, he was the Chief Medical Officer. And Jeff asked me to answer a couple of questions. And he said, if I had an opportunity to advise him, what would I tell him the department needed to do, and as the lead federal agency, the direction that the nation needed to head in to enhance its posture of preparedness to deal with events that, by their very nature, are going to be potentially overwhelming to our incident management capabilities. So the first thing I told him is that the medical and public health, critical infrastructure, and key resource sector has to be treated as CIKR number 1. And I said this for 2 reasons. One, the equation is Maslowian. At the end of the day, when severe environmental duress occurs, if everybody remembers Maslow's hierarchy of needs from Psychology 101, the bottom 2 plates of the pyramid are personal survivability and safety, and then familial survivability and safety. So my point is that when severe environmental duress occurs, we are going to, by almost reflex, turn to the critical infrastructure and key resource sector that provides that resource. And I will tell you that that's the big white H on the blue background. When bad stuff happens, we have inculcated our population to go to the white H on the blue background to try and get the support and succor they need to make sure themselves and their families are safe and will survive. The other thing I told him was that you need to look at the definition of incident management. And remember at the time, it was still look at the definition of consequence management, because prior to the adoption of NIMS and ICS as the formal command and control architecture by the Department of Homeland Security, we still called it consequence management. And if you go back in history, the organization that first provided the definition of CM was the Department of Defense. And the instruction actually came out of a chairman of the Joint Chiefs of Staff instruction, and the key words from that original definition were save lives, reduce suffering, and mitigate further harm against an impacted population. FH. So my point to Dr. Runge was, if you accept those definitions from consequence management, what other critical infrastructure and key resource sector plays a more important role than delivering these requirements? And luckily, he shared my belief. The second thing I pointed out to Jeff, and we'll get into sort of strategic perspective here, and what I'm drawing is the operational continuum. For those of you who have been in the military and have gone to any of the war colleges or command and staff colleges, you will be immediately familiar with this. And in the traditional operational spectrum, moving from left to right demonstrates the magnitude of an event that we might be involved with. On the low end, this might be a low-intensity conflict. On the high end, in the traditional military operational spectrum, that's thermonuclear war. Well, there's another way to depict this that's applicable to the homeland security environment. And we can actually add one more. You can say that this is the micro-tactical environment, this is the tactical environment, this is the operational environment, and this is the strategic environment. Now, this fits very nicely with the federal architecture, the state and regional, the local, and then because my concern always comes back to this micro-tactical level of organization are individual hospitals that provide the sustainment resource to individual and community preparedness. The way things work right now, we have severe fractures at what I term as the operational transition points between these locales as you progress along the operational continuum. And this was classically demonstrated. The case study for this is Katrina. And if you haven't read the book yet, it's by Peter Cooper, it's by Robert Bloch and Peter Cooper. It's called Disaster, Hurricane Katrina and the Failure of Homeland Security. And it provides, as I mentioned, a case study of this exact theory that I'm espousing here. If this was Nagin, and this was the governor, and this was the president, every time they tried to communicate with one another, they slammed into a fracture. And the reason is singlefold. And it's because we have no common architecture of planning that can be used at each of these levels. Right now, every one of these silos, and I'm introducing a concept I'm going to talk about in a second, every one of the silos along the operational continuum does it on their own. They have their own rules, they have their own regulations, they have their own approaches to planning, they have their own approaches to response and how they'll conduct operation, and there's no commonality amongst any of them. And I told Jeff that the thing to consider comes from the Department of Defense. DoD has done planning for a long time. And we've used it in the traditional national security architecture where the battlefield has always been where? A distant place. 9/11 changed the paradigm, didn't it? The battlefield now is here. Battlefield could be this university. This is a target of opportunity. This is a national icon. You sit close to a target venue that's already been impacted, and you're about 205 miles from Target Central, which I'll come back to in a little while, which is our seat of government in Washington, D.C. Now, the DoD, as an organization familiar with dealing with national traditional security threats, had a system that we used called JOPS. JOPS was the Joint Operational Planning and Execution System. And JOPS defined an architecture and an approach to planning that commonalized this approach no matter where you stood on the operational spectrum. So in military terms, you could be a Marine platoon leader here at the micro-tactical level, or you could be the director of operations at the Joint Chiefs of Staff, but your approach was common and identical everywhere along the line. The only difference, interestingly, is the granularity of the planning. At the most micro-tactical level, the granularity is deepest. You'll do this at this time with these assets to meet this mission requirement with this number of forces and this level of equipment. Whereas here, the speaker, the voice, is a more strategic voice. It could almost be called a policy voice, which is interesting to consider relative to how some of the federal partner agencies, namely DHS, might really need to function in terms of their roles and responsibilities in the domestic planning and security architecture. So what I suggested to Jeff was DHS, now that they have a responsibility for planning and responding in the domestic environment, has to have a planning and response architecture for the new security mission. Because if they don't have it, every time we have an event of national significance, for example, any one of the national planning scenarios, we're going to have a Groundhog Day syndrome, where we keep repeating over and over and over again what happened during Katrina. And I refer to this as fractious disparate planning, always leading to fractious disparate response. We'll never be able to talk to them in a common venue. Exacerbating this situation is the notion that was born out of an organizational theory that became popular in the mid or early 1990s and has been taken up by the National Preparedness Leadership Program run by David Gergen and Lenny Marcus at Harvard University. Am I allowed to say that school's name here? Is that okay?
I'm from Rutgers.
Oh, okay. So what siloization does is it kind of takes this and demonstrates how normally we are able to exercise leadership in a vertical continuum within these silos. Now let's label the silos for a second. This could be the federal silo, this could be the state, this could be the local, and this could be the hospitals that ultimately have to respond to affected populations. Or you could say that these are four competing organizations, cabinet-level organizations, that are waging war against each other for prominence, access to the president, the budget that they need, and they are not in the business of talking to one another. This vertical leadership is familiar, especially in the healthcare community. The more senior doctors exercise an almost brutal vertical leadership against the junior doctors coming in, but that's accepted. It's how we do business. What we suggest relative to improving this situation is that someone needs to step up to exercise horizontal leadership, what Lenny and David have referred to as meta leadership. Not to eliminate these silos, and that's a very important piece of what I'm talking about here. Nobody is arguing that the silos should go away. What's being argued, because each of the silos has a functional element that it provides, that's still a necessity. It's the parts of the whole that make the whole mechanism successful. But the meta leader or meta leadership organization is able to exercise leadership along a horizontal continuum to provide for a common mission. And that common mission, in this case, is preparedness and response. So the good news out of all of this is we're seeing a couple of things develop, mainly out of DHS. First off, Dr. Runge took this suggestion first to Assistant Secretary Forsman at DHS, and then to Secretary Chertoff. And they originally were calling it the National Planning and Execution System as a conceptual framework for preparing and responding to mega disasters within the domestic environment of the United States. The NPS morphed into what is now known as the Integrated Planning System, the IPS. And as the IPS stands, and it was just signed by the President not days after his inauguration, the IPS represents the new JOPES for DHS. Right now, it's an operational construct. Think of it like a set of instructions on how to commonalize planning regardless of where you are on the operational continuum domestically. And now what we want to see happen out of this is we want to see some type of resource architected around the IPS that allows for these organizations to take theory into practice. And one of the ways we're trying to do this right now, and it involves this area directly, is something known as JTF CAPMed. In recognition of how important the medical and public health community is to the preparedness and response mission, the Secretary of Defense created a special 3-star level command in Washington that is responsible for doing all of the planning for the defined national capital region, which is West Virginia, Virginia, Pennsylvania, New Jersey, Delaware, and the district. And the goal, ultimately, is Herculean by any measure, but it's one that we have to see come into effect. JTF CapMed's mission is to link, and by the way, this is the metal leader right here, is to link the military, other FPA, other federal partner agency, and civilian healthcare infrastructure exclusively. Not the electrical infrastructure, and not the security infrastructure, and not the law enforcement infrastructure, but exclusively the medical infrastructure for the purpose of enhancing preparedness and response capabilities in what is arguably the highest threat venue in the nation. And then the hope is, if this proves to be a prototype measure that has merit, this idea, this construct for a common framework can be taken up by DHS and touted as an application that can be replicated regionally around the United States to enhance preparedness. Much the same way NIMS and ICS became a C2, a command and control capability that can be commonalized across the U.S., the hope is that this is a construct that can be commonalized for the new C2, which is cooperation and collaboration amongst the critical infrastructure and key resource sector that we believe is going to be the one that, in the end of the day, adjudicates our success or failure at incident management missions. Thank you.
Great, thanks, Peter. And I'm probably going to be responsible for erasing and clapping out the erasers outside, bringing back memories. So we've heard three discussions. The first we heard about mega disasters and how the fact that we're unprepared for the mega disasters. The second we heard is what we might be faced within the construct of those medical disasters, the mega disasters, the medical and terrorism aspects of the boots on the ground people. And the third was the translation of a formal military process into a joint type of effort, and I'm getting flashbacks of rolling circles for that. And within the construct of that, the concept, again, of meta leadership, and if people have read the Booz Allen paper, the mega community, that encompasses that. So with that, what I'd like to do is first ask our panelists, based on the other discussions, any questions or points they'd want to bring up that interact with the other panelists, and then if we could open it up to the floor. So any comments on or additions you would like to make based on the fact that we have 5 minutes for you again before we open it up to the floor?
Well, it was very interesting to hear the other two panelists, and a question for each of them. One of them has to do with, we saw the picture of the strategic national stockpile cache of stuff. And my concern about that has been from the beginning, is it enough stuff and is it the right stuff? And we don't know. Again, there's a denominator failure here. Those caches will be delivered, let's say nerve agents, 4, 6, 8 hours after the fact, and they will be not needed. They will be too late if it's in fact a nerve gas attack. There's IV stuff in there. There's antibiotics. Is it enough? Measured against what? And this is reflective to me of the extraordinary degree of arbitrariness that we've seen in a lot of the planning. We saw a picture of decontamination units. New York City's St. Vincent's Hospital a few years ago, with great fanfare, announced that they were building a new ER and had 16 decontamination units. I said, well, how many does the city need? Do we need 1,600, 160, 12? I mean, what? And there's nobody who can answer that question. That leaves us in a very odd position here. And so I wanted to get Leonard's reaction to that. And Peter, I would like a little more understanding about how this new formulation will translate down to New York or Chicago or LA in terms of how they will effectively use these assets or even this system to materially improve the ability to plan for a response in face of a really, really large, let's say, nuclear disaster or a 7.5 Richter earthquake in San Francisco. Is it gotten down to that level of operational capacity?
If you don't mind, I'd like to address very quickly the strategic national stockpile point that you made. The SNS was arguably the most significant public health preparedness initiative that was accomplished in the last 20 years. A total leaning forward by CDC and HHS to place regional response assets that ultimately had the ability to do one very most important thing, and that is reduce the tyranny of distance relative to response time to support an impacted population. The theory, whether in the military or in public health responses, is that if you can't get the resources to where the battle is occurring, they have zero utility on an affected population. And that we once came up with an acronym in the military to describe that population. The acronym is DITTER, and it stands for Dead, Dispersed, and Recovered. If the stuff isn't there on time, it just has no reason to even be in place. So the theory of the SNS was beautiful. The problem with the SNS is twofold. One, to this day, only 2 states across the United States have been formally adjudicated by CDC and HHS as having adequate hub and spoke plans from distribution of the SNS stockpiles once they're received within a particular state. And those states are Florida and Illinois. So getting those resources down to the end user, meaning any individual citizen, is problematic and a very significant issue. The second issue with the SNS is something you've already alluded to, Erwin, and that's the actual makeup of the SNS platforms. It can be argued that it's going to be great for a slow bloom bioterrorism event where you can get antibiotics and vaccine into the hands of people who may have been exposed. On the other hand, it's sheer folly to have chemical antidotal material as part of the SNS platform when you need that in first responder ambulances so they can respond within the 3-minute window of an exposure to organophosphates like sarin or cyclosarin, a la the Amshinrikyo scenario in Tokyo. So it may be time that CDC did a rheostat of what that platform encompasses and make it more utilitarian, first off, and then second, engage with the state and local authorities to try and bridge that existing gap regarding the distribution plans. Your second question about how this is going to come down to the local level, I think harkens back to my comment about NIMS and ICS. NIMS and ICS is born out of 2 areas. One, the Unified Command Plan, Command and Control architecture, the DoD, and then the California Forest Fighter Service Command and Control architecture. And it's been proven time and time again to be very effective. When DHS adopted it, it was in recognition of the need to have some commonality in how we approach the incident management mission. And the way they got the state and local folks to buy into it was through nothing more than the grant process. If you wanted to be eligible for the grants, you had to demonstrate NIMS and ICS compliance, and that became the level of surety in getting everybody to buy into the process. So I think that we're going to see that, if this comes to pass, we'll see that process happen much the same way.
Dr. Cole, anything to add?
Yeah, I'll try to be brief. Strategic National Stockpile. Nobody in this room has a sense exactly of what's in it, unless somebody does and they're at level. You do? Okay, so then maybe you have more authority to say what you've said than I am about to say. Depending on the quality of the nerve agent and the capability for degradation, and some of them, like VX, can remain for weeks at a time in a highly lethal state, it would not necessarily be so that unless a patient is treated immediately, then there's no value. While I certainly agree it ought to be part of a local armamentarium, the fact that it's in the Strategic National Stockpile I don't think would necessarily be a mistake. Similarly, if, Erwin, you say you know what's in it, and you certainly have an authority to say, well, what are we preparing for? And I heard you talk about the decontamination capabilities. 16 showers enough? 50? What do you need? I don't know, and nobody knows. And we have misjudged so many times, not just in recent decades, but historically, as humans try to fight the war. Often enough, they're fighting the last war, and something new comes up. And I'm going to sound very foolish in what I'm about to say, but I subscribe to what the U.S. Treasury leadership says now, not only Geithner but others who say it's better to do something than to do nothing, which is a very unsettling response. But at the same time, there are many valuable parts of any strategic national stockpile that under some conditions could be extremely helpful and necessary, but I don't know what the numbers are, and maybe you can help us talk beyond whatever the classified aspects of it to either counter what I just said, or maybe support some of what I said.
Actually, if I could exercise moderator's prerogative on this, because a lot of the criticisms we get from conferences is the audience doesn't get to ask any questions. So with that, but I also will accept one other moderator's prerogative, and that's to clarify some S&S points. And that number one is that the CDC has recently instigated a new grading system that does in fact change the evaluation process. The second is that the CDC will, and this, I'm not defending the CDC, I'm trying to put out facts here. The CDC will be conducting a multi-state exercise to test I believe in the fall, to test exactly what you're questioning, which is what can they do during a multi-state event in which there's competing requests for the stockpile. So with that, questions?
Especially on Mr. Margiela's comments and on the issue of communication and coordination in emergency response, and especially in public health. We have a real-life experience right here in Princeton that I appreciate your comments on, because I think it's a very good example of what a lot of the national and regional issues come down to, the local situation. They say all politics is local, and in many ways that's true. Princeton is a relatively well-educated and well-off community, and it has a strategic facilities and location, as was pointed out. As a member of the Princeton Board of Health here for 13 years, just retired a year ago, I and many other members of the Board of Health made a multi-year plea to our local government to assign someone to be a part-time emergency response coordinator to communicate and coordinate the activities of various municipal emergency response units here, including the police, fire department, health department, hospital, university, etc. This discussion, to have such a coordinator, and it could have been somebody who was currently employed and who could have been diverted half-time, and it didn't have to be very expensive. It started...
Can I interrupt? I mean, we need a question.
Yeah, there is going to be a question.
Please, because we have a lot of other folks.
This started in 1999 after Hurricane Floyd, so it was not, and then was heightened after 9/11. Even with the repeated requests of the health department here to have such a person, the local government would not allow it. And we did have the anthrax attack problem here in the mailbox.
Miss?
So the issue is, in a community like this, I mean, it comes down to decisions like this. What comment do you have about that? It's very frustrating to us locally.
Well, I quickly say, two things. I agree with your point. It's a well-standing axiom of planning that, and in disasters, that leadership is local. Disaster is always local first, and the impact's always going to be felt locally. So it's sort of a mandate that local organizations that will have to deal with it engage in the planning process. The other comment about whether you can get somebody like that to step into what I would define as the meta leadership role, goes along the lines of whether good leaders are born or made. In this case, if your community recognizes the need for somebody to step into the space, then the community needs to make a meta leader and say your job is to try and affect a partnership across the various silos of the organizations that exist in the community with different but like roles in this common requirement of keeping your community safe and resilient.
Okay, to maximize questions and answers, if we could get the question, if we have a question about the question, how about if we ask that so we can maximize that? Dr. Flynn? And then Dr. Pruden?
As something of a follow-on, I think, from the last question here, how do you manage the fact that the trends seem to be going all the wrong way from what you're prescribing, particularly, I guess, in terms of this micro capacity? That is, the movement, obviously, in the health community is to wring redundancy out of the systems to get efficiencies. On the other hand, we have public health budgets imploding in every state around the country virtually. And the federal resources for supporting public health were flat out, were taken out of last year's budget. So basically, how do we square your sense of urgency, need to build this added capacity to deal with mega disasters and these events with the reality that these micro decisions are being made to diminish that core capacity?
Dr. Redman or Dr. Cohen?
You know, big policy decisions are driven by at least two spectrums of forces, one being weak politics versus strong politics, and the other being weak science versus good science. So if we knew for a fact that what we were losing would have a detrimental effect either on the stability of the public health system or our ability to get prepared, that would be, and we had evidence for that, we could make a case, and we have quite good evidence for that. But if we don't have strong political force behind the use of that knowledge to change a policy decision, then we're sort of left hanging there. The problem being that if you took the average public health expert and said, we have limited resources, if that was a caveat, and we have to divide them between general public health systems or supporting hospitals that are now on the verge of bankruptcy, which is about a third of the hospitals in the U.S., where do we put the limited dollars that we have? That is a debate that we just actually have not had yet. And I think those people who say we should be investing much more in general public health infrastructure, capacity building, have a strong case to make because it helps both the general public health agenda as well as us getting more prepared. A couple of days ago, it was finally announced that New York State would no longer be putting CDC or transferring CDC money into local county public health departments. So all their functions around preparedness are evaporating as we speak. My staff was in an uproar, and I said, well, do we know if that's going to make a difference? Is it going to be replaced by other people, other agencies doing the same functions? There's just an information paucity. But I think the question you're asking, Steve, is a critical one when resources are limited. We have to figure out the mechanism for understanding priorities. Do you have suggestions yourself? I mean, it's funny you're asking me, really. Usually.
Dr. Cole, do you want to add to that?
Please. Together, it's not talking about reform of general capability.
Yeah.
In the absence of talking about the terrorist major capability, the two have to be together.
Yes. Well, I concur with everything. This is 99% political, 1% having to deal with the science in terms of whether we're going to see this unfold in a way that should be. And given the pressure, the economic pressures, and the fact that the last major terror attack on the United States is 7.5 years back, will become an increasing problem. There may be no way out of it, but the best that I can suggest is that people like you who testify before Congress and people like Irwin and to some extent others in the room, myself included, who have contacts with public officials and decision makers, continue to make the case. If I may, parenthetically, I wrote a piece for the New York Times, an op-ed piece about a year and a half ago. David was quoted in it. I don't know if he was happy with the quote. But I likened the necessity to prepare, not for mega events in general, but terrorism, to preparing for fires. I spoke to many of the presidents and CEOs and others of hospitals in this state, and I said, when's the last time you had a major hospital fire in the past 10 years? And almost everyone said none, no major fires. Maybe a toaster burned and there was a short circuit. When's the last time your hospital was involved with a terrorism event? And sometimes they needed a little reminding, but a lot of hospitals got an overflow crowd after 9/11 who had crossed the river. Some of them were overwhelmed with the worried well. After the anthrax event, the Robert Wood Johnson Hospital in Hamilton, right? Saw 1,300 patients who were postal employees who were worried that they might have contracted. Fortunately, almost all of them were negative. But what would have happened had there been a real surge in need? The hospitals would have been overwhelmed. I think it brings the case, when you talk about analogies, it's not terrifically scientific and it is anecdotal, but if the anecdotes are true, they can sometimes resonate and create the emotional necessity, the psychological necessity in the mind of a public official who might not be so impressed when you say, hey, you know, our public health system is not doing well, we ought to give it more money. Accurate as that may be, it doesn't have a terribly strong emotional impact when you say that.
Great, thank you. I think we have a microphone over there.
In the vein of addressing your silos or commenting on that, what strategies are in place or should be in place to eliminate some of the federal requirements that impede our ability to respond to disasters? For example, India Mess requires that the event cross state lines, crosses state lines in order for you to utilize those resources. With HIPAA, the evacuation of hospitals in Louisiana, they were unable to get information about patients they sent to another hospital. HIPAA prevented them, or that was used as a way to keep them from coming back. Within TALA, the hope of setting up alternate triage sites within a hospital ground to send people to another facility would be a violation of TALA. Is there a strategy to release these federal requirements that impede your ability to move beyond those requirements of the disaster? Question number one. Question number two, unrelated, is alternate sites of care, considerations of alternate sites of care using volunteer resources. With medical reserve corps and ESAR did in its infancy, what are you doing to capture the people who could be your resources, identify those people who could be your resources, making sure you're not double counting these people so when something happens, you think you have more than you actually have?
Well, first off, I'm not in the federal government, per se. So I can give you my sort of op-ed opinion, having been in the federal government and having been involved with many senior planning initiatives, but I can't answer that as if I was the director of operations at HHS or Rich Besser at CDC. The federal guidelines that are put out in seminal documents like the National Response Framework, the Pandemic Influenza Operations Plan, the Pandemic Influenza Implementation Plan, et cetera, are guidelines. The conundrum that the CDC got into when they decided that they wanted to write a national operations plan was that the plan could only be treated as guidance to the state authorities, the state public health authorities, because of the issue of state sovereignty. There's lots of good people in the federal government who are thinking good thoughts about these strategic level problems that we face in this emerging concern of mega disasters that might occur in the United States. And many of the programs and ideas that you cited in their conceptual framework are really good ideas. It's getting them through implementation and getting buy-in at the subsequent levels of that operational continuum I described that's problematic, for all sorts of reasons. You get pushback from the state, you get pushback from the locals, and even the federal partners don't necessarily observe the roles that they are supposed to maintain. It's no great secret that even though DHS is the presidentially designated lead federal agency for any domestic preparedness and response planning capabilities, they are still at odds with HHS as the lead for ESF number 8. Why? Because they're both cabinet-level organizations, and as secretaries, they have the ability to say, well, listen to me, Mr. President. Subjective opinion, a kind of reality, a mix of both. So I can't offer a definitive answer. Quickly remind me of your second question, please.
Actually, I'm going to allow you, Doc, only one question, so I can get to another question if you don't mind. Dr. Khan?
Yes, thank you. Just a couple questions on meta leadership. How does it fit in with the U.S. Constitution's separation of federal and state powers? Who exactly is going to serve as a meta leader? And what would be the roles of state and local elected officials in this type of scenario? Wouldn't one argue that they are natural meta leaders and should serve in that role?
First of all, I think that the meta leadership, the reason I'm addressing this is New Jersey just went through a meta leadership conference with Dr. Dorn,
Lenny Marcus,
and Barry Dorn, who came down here, and there was the leadership here. And I think to clarify, and all their information is on the website if you just Google meta leadership, so to put that as a reference. But there is no intent to take a authority away from anyone or grant authority to. In essence, it's as Peter said, it's the granting of horizontal and vertical working together relationships to people at the level of people who can make decisions. But I want to give it to Peter for the rest of it.
I would just add to that meta leadership, it shouldn't be taken as a single individual or a single initiative. I'd suggest you take it as a philosophical approach. Meta leadership could be multidimensional. It could be, multiple organizations who all understand that working collaboratively is going to enhance, it's the sum of the parts make the whole better. And that in and of itself is buying into the conceptual framework of meta leadership. So I wouldn't necessarily get stuck in the legality or authority issues of who can be the person and what control can they exercise versus buying into the concept or philosophy of what meta leadership can mean in trying to get our arms around situations that are by their definition inherently problematic and difficult to control.
Yes, I have a question primarily for Professor Cole, I believe, but whoever. This concerns appropriate, or what could be appropriate and massively life-saving medical response, type of medical response to a major event in which there's massive bleeding in many people. There is extensive evidence, historically, going back to Hippocrates, that hypothermia can buy time, can control bleeding, can greatly improve the survival rate in incidents where there's massive bleeding. It happened to me. I was a hit-and-run victim in a rural area, hypothermia victim. A beneficiary of hypothermia, and I survived. Okay, what about cooling blankets, cooling mattresses, cold packs, simple means of providing a type of hypothermic response, inducing hypothermia in types of events where you would expect there would be massive bleeding?
Well, you did say me or whoever, so I'll start with me. Because of your personal experience, I'm sure this is extremely acute in your mind and thought, and it's obviously a very important problem, but there are so many other equivalent acute emergency needs that could be treated not involving hypothermia, but involving other initial approaches. In a seriously mass casualty event where there are hundreds and hundreds of people lying around, without preparedness, you won't be able to do what, again, the Israelis do now. They have an incident commander. The first person to arrive who comes from their EMS system becomes the incident commander and quickly makes triage decisions in seconds. Sometimes they're wrong, but they've learned to be right far more often than wrong about who gets what treatment. And if there's massive bleeding and the person doesn't look as though they're a good candidate for survival, they're going to be passed over to go to the next person who may have a better shot at it. Terribly gross approach, but necessary if you're dealing with hundreds of people, many of whom could be saved if appropriately taken care of, if they are seen as savable. So I don't have a better answer than that.
Oh, let me just respond in this way. First of all, I think you're absolutely correct. This is an extraordinarily important intervention that actually saves brains from being deprived of oxygen and blood supply. Again, it's a challenge of scale. So if one person comes into an ER that's equipped to do this, and the ER knows what to do, it will happen. If 10 people, it'll happen. If 50 people, it'll probably happen, maybe. When you start getting to the level of casualties that we might see in a massive earthquake, let's say, with that amount of people in a major city who need this, or in a nuclear situation, or other kinds of really large-scale disasters, the capacity is really overwhelmed by the need, and that's a cost issue. So how do we actually organize that and make a decision that we're going to spend whatever money we have on that versus some of the other things that Leonard was talking about? But you can imagine that it's not like anybody disagrees with the premise. It's just that we haven't figured out how to scale it up so it could serve as a useful primary intervention for potentially thousands and thousands of injured and hemorrhaging individuals.
Okay, thanks. I think I've been given the last question. So.
In the professional literature, there are observations that if we were serious about emergency preparedness, we would be creating emergency preparedness audits for different facilities like chemical plants or hospitals. And we have done that in the computer industry with information security auditors and audits. It's done for nuclear plants. Don't you think it's time professionals in the medical field got together and with other disciplines that created emergency preparedness audits for hospitals and clinics and places like that?
Well, funny you should mention, I just had a call yesterday from the Joint Commission which accredits hospitals and ambulatory healthcare facilities. They've been trying for years to get standards of hospital preparedness with enough teeth in them so that the hospital has its accreditation dependent upon, among many other things, its ability to demonstrate actual levels of preparedness. The American Hospital Association ferociously opposed that and has not yet materialized. This particular JCO official now is in the private sector but still pushing for this, and this is another political issue more than a question of whether it's a good idea or not.
At some point it's going to be forced on you if you don't do it yourself.
I think in some ways it has been, and the Trust for America's report, which I will neither agree or disagree with, has put in the public eyes some sort of measures that are to grade health systems. But I think the key issue is getting down to what was stated earlier by Dr. Redlener. What are those criteria that you should use? And those have not been defined. So before you're able to grade, you have to define what you're grading, and we have not seen that.
Together, get them tasked to develop those standards.
There's also nothing to say that the Joint Commission priorities are at all in line with what the national priorities are for.
I would say that at the national level, both at HHS, the Assistant Secretary for Preparedness, and also at CDC, they're both working on developing the metrics for those. It has been a long process, and quite frankly, they're still not there. But there are people that constantly question what those metrics should be. You're working with something, as again stated with one of the panelists, where there's no empirical data to base your metrics on. And consequently, you're speculating on the metrics, and consequently, even if people meet the metrics, for example, the national stockpile grading right now, you don't know if that's going to work. So I think that's what people are struggling with. But you're absolutely correct. There should be a way for doing that. I'll add one more pitch to what we're doing, and some of you who are on our HEPAC committee know that. We as a state have asked our advisory committee to develop metrics to grade ourselves. And, you sort of got to be careful what you ask for sometime, but recognizing that.
One just quick comment. In the 50s and 60s, the government sponsored extensive studies of organizations that went through crisis and disaster situations. They came up with the observation that those that did the best performance did, in fact, allow decisions to pass to the lower level and act laterally across. Oversight was maintained at the top, but they also allowed for innovation so that you didn't have plans that dictated the decisions to be made, that dictated the process. And the important thing to observe, even in 9/11, we had a sergeant go out and discover that a ferry could be used as an ambulance, get people to the New Jersey shore for the National Guard hospital there. No plan ever said that an ambulance would be a ferry.
And with that, I want to thank everybody on behalf of the panel and turn it over to